Hello everybody and welcome to our module on urinary infections. In this module we're going to talk about two infections of the urinary tract, and the first is called cystitis, and that means infection of the bladder. And we often describe this as a lower urinary tract infection. Contrast that with the second type of infection, which is pyelonephritis. This is infection of the kidneys themselves, and we often describe this as an upper urinary tract infection. So with all types of infections, it's important to know how the bugs get into the body. And in the case of urinary infections, they usually ascend, which means they enter through the urethra, they travel up to the bladder and cause cystitis, and then they climb all the way up to the kidneys and cause pyelonephritis. And that's the mechanism by which most bacteria that cause these infections get into the urinary system. Most of the bacteria that cause urinary infections are enteric bacteria, and far and away the most common is E. coli. It causes about 80 to 90% of all urinary tract infections. Other bugs that can cause urinary infections are Proteus mirabilis. This is a urease producing bacteria. And if you watch the module on kidney stones, you know that this is the bacteria that can lead to struvite kidney stones. And then some other occasional causes of urinary infections are Klebsiella pneumoniae, Staphylococcus saprophyticus, and Enterococcus fecalis. So let's talk about the symptoms of cystitis. So patients with a bladder infection often complain of dysuria, and this is pain with urination. It's often described as a burning type of pain. They also complain of frequency, which means they go to the bathroom a lot, and also urgency, which means they always feel like they have to go. Even after they urinate some liquid, they still feel like they have to go. They can have pain in the suprapubic region, and importantly, there are usually no systemic symptoms if you have a bladder infection, so no fevers, chills, or sweats. And usually there's a normal white blood cell count in the plasma. Contrast that with pyelonephritis. So patients who have a kidney infection generally have systemic symptoms like fevers and chills. They'll complain of pain in the flank, which is on the side between the rib cage and the hip. They'll have costovertebral angle tenderness. So if you tap on the lower back of a patient with pyelonephritis, it will hurt a lot. That's what's called CVA tenderness. There'll also be blood in the urine, that's hematuria. And then they also have something called white blood cell cast when you look at the urine under the microscope. This is a white blood cell cast over here. So all these white cells have been pushed together as they pass through the kidney and the ureter, and they form a cast like this. And that is suggestive of pyelonephritis. Now remember, these infections ascend to the kidney, so patients with pyelonephritis may also have symptoms of cystitis like dysuria and frequency and urgency. But if it's an uncomplicated cystitis, they won't have any of this stuff up here. If you see systemic symptoms and flank pain and CVA tenderness and cast, then you know that the infection has gone all the way up to the kidneys. So let's talk about how you make the diagnosis of a urinary tract infection. The first thing you can do is urinalysis, and the easiest way to do a urinalysis is just look at the urine. So in the hospital, patients with UTIs who have a Foley catheter in will be draining cloudy urine into the Foley catheter bag. You can also see this in a urine sample of someone who has a UTI. In addition to just looking at the urine, you can do a dipstick test. So this is a picture of a dipstick, and you literally dip it in the urine and then wait for the color to change of the different markers. One of those markers is leukocyte esterase. So you will have positive leukocyte esterase on a dipstick of a urine in patients who have white cells in their urine. The white blood cells produce leukocyte esterase. Another one of the markers on the urine dipstick is for nitrates. So 90% of UTI bugs convert nitrates into nitrites, and so the dipstick will pick up the nitrites. So there are a couple bugs that don't. Enterococcus doesn't, Staph saprophyticus doesn't, but E. coli, which is the most common bug, does. And so when you see leukocyte esterase and nitrites positive on a urine dipstick, that tells you you're highly likely to have a urinary tract infection with E. coli. You also can look at the urine under the microscope, and if you see more than 10 white blood cells per high-powered field, that suggests a UTI. And then finally, the ultimate way to diagnose is to send a urinary culture. And if you can grow greater than 100,000 colony forming units on a culture plate, then you definitely have a UTI. So who gets UTIs? Well, first of all, they're much more common in women, 10 times more likely than men to get UTIs. This is for two reasons. First, they have a shorter urethra, so it's easier for those bacteria to climb up to the bladder. And also their urethra is closer to the rectum, so it's easier for fecal flora to get into the urinary system. Women who've had sexual activity are at particular risk because the sexual activity can introduce bacteria into the urethra, and UTIs that occur after sexual activity are sometimes called honeymooner's disease for obvious reasons. Patients who've had a urinary catheter inserted can obviously get UTIs. People with diabetes are more likely to get UTIs, and in fact, if you diagnose a UTI in a man, one of the first things you should think about is that he may have undiagnosed diabetes that set him up for that urinary tract infection. And then women who are pregnant are more likely to get UTIs than women who are non-pregnant. Some other risk factors have to do with urinary flow. So let's do a drawing here. If this is your ureter, if the urine is flowing briskly down the ureter, any bacteria that may get in here will be pushed out by the good urinary flow. On the other hand, if you have a ureter with very slow trickling urinary flow, it makes it much easier for those bacteria to get inside and climb up into the urinary system. So any patient who has poor urinary flow is more likely to get a urinary tract infection. So who has poor urinary flow? Well, infants who have vesicoureteral reflux have ureters that insert abnormally into the bladder. So they have a chronic reflux of urine back into the ureters. This means they have poor forward flow of urine and they're at increased risk for infections. People who have a urinary obstruction for any reason are at increased risk for UTIs. So anatomic abnormalities in children can lead to this, bladder tumors in adults, or men who have enlarged prostates. All these groups are more likely to get urinary tract infections. The mainstay of treating UTIs is with fluoroquinolone. So these are antibiotics like ciprofloxacin, levofloxacin, and ofloxacin. Usually a simple 3-day course will clear out the bug. In pregnant women, nitrofurantoin, which is also called macrobid, is often used because it's safe in pregnancy. And then another drug you can use is trimethoprim sulfamethoxazole. This is called TMP-SMX. This used to be used a lot before fluoroquinolones came along, but the fluoroquinolones have less side effects, and most people will reach for one of these if they see someone with a UTI. Let me mention sterile pyuria. So some women who have chlamydia or gonorrhea will complain of urinary tract infections. Now, as you know, chlamydia and gonorrhea are often asymptomatic, but there are some women who will say that they have dysuria or frequency or urgency. And if you do a urinalysis in these people, you will see white blood cells. So there will be pyuria, but there will be no bacterial growth. So anytime you see sterile pyuria, you should think that there may be a sexually transmitted disease from chlamydia or gonorrhea. The last thing I'll discuss is chronic pyelonephritis. So this is something that happens when you have recurrent bouts of pyelonephritis. Usually it occurs in children who have vesicoureteral reflux, and it can also occur in adults who have recurrent kidney stones. And these patients will get scarring of the kidneys. So the corticomedullary area of the kidneys will have scar tissue laid down. They'll also have something called blunted calyces. So let me tell you what I mean by that. So if this is a pyramid in the medulla right here, normally the calyces go up and fork to collect urine and bring it down into the renal pelvis and the collecting system. In patients with chronic pyelonephritis, those forks get blunted off. And you can see this on radiologic imaging. You won't see the sharp forks. You'll just see a blunted, rounded calyx like this, which then brings urine down into the collecting system. The other finding that these patients have is something called thyroidization of the kidney. So when you look at kidney biopsy samples under the microscope, tubules contain an eosinophilic material that looks just like thyroid tissue. And these things, corticomedullary scarring, blunted calyces, and thyroidization of the kidney, are all findings in chronic pyelonephritis. And that concludes our module on urinary tract infections.